This is class 2 of the hormone replacement therapy for menopause series. Today we're going to talk about estrogens, and this talk is really aimed at patients. For clinicians, what I'll do is put a page of references towards the end of the series that you can look at on your own. Estrogens are the hormones that dominate the complex web of female hormones. And we know that they influence breast tissue and uterine tissue, but they also influence bone mass, sometimes mood, sometimes cognitive health, and cardiovascular health. Medically, we focus our prescriptions on 3 types of hormones: E1, which is estrone, E2, which is estradiol, and E3, which is estriol. The different estrogens react differently at different receptors in the body, and that can cause some of the risks as well as some of the benefits. The estrogens are also broken down into different products, and those have different reactions throughout the body. Premarin, which is the hormone we talked about in the Women's Health Initiative, is a mix of 10 different estrogens, but it's predominantly E1 or estrone. Premarin has proof that it decreases hot flashes as well as improves bone health, but there are some risks with it as well. Functional medicine teachings discourage the use of estrone or E1 orally or topically because there seems to be evidence that many women will incur a higher risk of breast cancer and heart disease than if they're not using estrogens at all. Conventional medicine still finds a place for Premarin for many of their postmenopausal women. However, many conferences that I've attended about menopause show even conventional physicians really are leaning more towards using E2 or estradiol. Estradiol is currently the most commonly prescribed form of estrogen replacement therapy in the United States for postmenopausal women. This is currently available as pills or in topical forms, patches, creams, and suppositories. Estradiol is bioidentical, meaning it is the same chemical structure as what our body makes by itself. Estradiol has been shown to decrease hot flashes, improve bone strength, and decrease vaginal dryness. Both functional medicine and conventional physicians prescribe topical estradiol as a safe option as long as it is balanced with progesterone in any woman who has a uterus. Estriol or E3 is currently prescribed mostly with estradiol as a topical preparation, so either vaginally or placed on the skin. It is currently available only through compounding pharmacies in our country, and it is not FDA approved. Estriol is also a bioidentical hormone, and it's usually prescribed when somebody is suffering from vaginal dryness. I have used it in postmenopausal women who have recurrent urinary tract infections, and it seems to help. Estriol does not get presented in my conventional menopause treatment conferences, so this is something where there's some disagreement about the utility or the validity of using estriol. To make things more complicated, the different types of estrogens can convert between each other to some extent. And this is part of the really awe-inspiring complex web of hormones that we talk about. And it can be thrown off when you put in an estrogen or any other hormone from an external source like a pill or a topical prescription. Taking estrogen stimulates the lining of the uterus, and that can lead to an increased risk of uterine cancer. So whenever we are prescribing estrogens for a woman who has a uterus, we also prescribe progesterone. So we will talk a little bit more about that in the next class, which is all about progesterones. Hopefully this was helpful, especially for the 2 patients who nudged me along to get this out today. Next class, so class number 3 will be about progesterone, and then class 4 will be about some of the other hormones like DHEA and testosterone.